list, and it's called cardiac. Here, I'll go ahead and everyone see that okay? What I'll do is I'll go ahead and open this up and show you guys real quick. So if you just click on the PowerPoint folder here, it's RT Pharm Cardiac and Blood Agents. So I'll be using those. Now, you guys are more than welcome to download the lecture from, was it package 4, I think, is where it came from? Yeah, so if you open up package 4, it'll go ahead and it'll take a few seconds to open up. I'd recommend doing this actually here at the college because we have nice high-speed internet, and it's literally a matter of seconds. And there's your PowerPoint, Chapter 9. Again, I won't be using that PowerPoint. I think it's just a bit too confusing for what we need to learn here. So I have my own I made for you guys. And we will go ahead and use that one. I am actually going to start off lecturing, and I'm going to keep the projector up, or the screen up, because I'm going to be drawing all over the board, and I want to be able to draw on top of the pictures that I have. So, can everybody see this okay? You guys in the back, are you okay? Okay. Is there too much light back there? No. No? That's good? Okay, let me know, and I'll be more than happy to turn that light off. Okay, so, did you guys do the reading? Be honest. No. Okay, I didn't think so, because the reading was about as confusing as the reading was about as confusing as the PowerPoint. So that's all right, because I didn't expect anyone to read. Because if I were in your shoes, I probably wouldn't have read. Or I would have started reading. I would have gone, this is.
That's exactly what I did.
Okay, so we're going to talk about cardiovascular and clotting agents today. I believe they call them antithrombotic agents on the syllabus in the chapter. But antithrombotic agents, as we're going to learn, only apply to a very certain area of the clotting cascade, and we want to cover more than just antithrombotic agents. Okay, so hopefully everything ported over. I don't actually have PowerPoint. I use Keynote. So sometimes things get lost in the translation when I translate from Keynote over to PowerPoint. If everybody would just use Macintoshes, we'd be so much better off. I don't see that happening, but all right. So let's go ahead and get started. First of all, I just want to hit some basic terminology, just so we're all on the same page. What is inotrope? What does that refer to when we talk about an inotropic agent?
Contraction.
Okay, good. And what do you mean by like? Somebody kind of got on was close. I heard a word that was close, but what about the contraction are we talking? The force. There we go. Somebody said. So it's the force of the strength of contraction. So if I give a medication that's a positive inotrope, if I were to say that was a positive inotrope, what would we assume that medication would do? It would cause the heart to contract stronger, right? Yeah. Not necessarily the rate increase, but the actual strength of contraction increasing. Does that make sense? Mm-hmm. Likewise, if a medication has negative inotropic effects, what would I expect to the strength of contraction? It decrease. Okay, good. Okay, what about chronotropic or chronotrope? What does that refer to?
The rate.
Okay, this is the rate. Okay, chrono being time. Okay, so the rate of contraction. So if I say something has positive chronotropic effects, I would assume what? Increased rate. Okay, negative chronotrope, decreased. Everyone's okay there? Okay. There's also another term called automaticity. What is automaticity when we talk about the heart? What's that? Close. Getting there. So what does auto mean here? Automatic. What do you think about automatic?
It does it by itself.
Okay, so automatic is something doing it by itself, right? It's something doing it. It's involuntary. And what that refers to is the heart. You guys remember from anatomy and physiology, the heart has different pacemakers, right? That's kind of set the pace of depolarization, how often an action potential occurs. And what is the primary pacemaker of the heart? The SA node, right? The sinoatrial node. The SA node. Now that node, it has a certain amount of automaticity, right? It fires automatically. And that is to say, if I were to take that heart, and I were to tear that heart out of you, and then put it back in, and assuming that you survived and all that, would you guys agree that the nervous system would be cut from the heart? That we'd have to cut all the nerves away from the heart? Well, will the heart stop beating if I cut all the nerves away? No, because the SA node has its own intrinsic set rate of firing, right? And it has what we call its own automaticity. And what is that rate, that intrinsic, the normal intrinsic rate of firing the SA node does? Well, what's a normal heart rate? 60 to 100, yeah. So the inherent automaticity of the SA node is 60 to 100. Now, I can give certain medications, or I can have certain problems with the heart that can affect the automaticity, or certain areas of the heart have different types of automaticity. We know the SA node has a fairly quick rate, but if the SA node were to fail, and some cell, maybe in the ventricles of the heart, were to take over the pacemaker, would it have the same automaticity as the SA node? What do you guys think? No, it's down lower, so it has a much slower rate of firing, right? And you guys remember from anatomy and physiology, they talk about different pacemakers of the heart failing, and as the pacemakers fail, generally what happens to the heart rate? It decreases. It becomes slower and slower and slower. So if the SA node were to fail, then maybe the AV junction would take over as the pacemaker of the heart. But we know that the AV junction's automaticity is lower, right? And you're looking at only about 40 to 60. And if that were to fail, and all we had left were ventricles, we know that their set automaticity is much even slower, right? And you're looking at about 20 to 40. But can we have certain conditions or medications that can affect the automaticity? Yeah, absolutely. And we can influence the automaticity of these certain areas of the heart with certain medications. What causes automaticity? What do you guys think? What causes automaticity? Yeah. There you go. It's a sodium channel, yeah. And cells that have automaticity, that can automatically depolarize, they have a little channel in them, a little leaky sodium channel. And it always leaks, and sodium slowly leaks into the cell, and then after a certain amount of time, what actually happens to the cell once enough sodium leaks in? It depolarizes, right? It depolarizes and have an action potential. That is how these pacemakers work. They're leaky. They have a certain amount of leakiness to them. Sodium leaks in, and eventually once enough sodium leaks in, it depolarizes the membrane, right? It causes a depolarization. And we know that the cells of the SA node are leakier, if you want to look at it that way. Sodium leaks in faster, and they can depolarize faster. Versus cells down in the ventricles, where the leakiness of the sodium, if you want to look at it that way, is much slower in those cells. Okay, and then the last bit of terminology is something called Droma Trope, or dromatropic. What do you guys suppose Droma Trope refers to? It's kind of it has to do with conduction. It's a very non-intuitive conduct. It has to do with conduction. And what is it? How is it describing conduction? What do you guys think? Not the rhythm.
The rate?
The rate of conduction. There we go, the rate. The rate of conduction. So something is positive, has a positive Droma Trope, it's going to speed up the rate of conduction. That is to say that the wave of depolarization will conduct faster, and a negative Droma Trope will decrease the rate of conduction. Does that make sense? So increase and decrease. And we know as a general rule, the wave of depolarization generally has to conduct through the heart pretty quickly. Would you guys agree? And in fact, it is so important that I have quick conduction. You guys remember from the heart-lung lab that we did, what is special about cardiac tissue, the myocardial cells? What special structure exists to help ensure I have speedy conduction?
Is it those intercalated?
There you go, the intercalated discs. Absolutely. All right. So everybody's good on the basic terminology that I may end up using this. I may say this medication is a positive inotrope or whatever. I just want to make sure everybody's on the same page here. Okie dokie. So cardiac conduction. So in your notes, if you look at Chapter 4 notes, there are a couple pictures like this, and then it shows you every cardiac rhythm you can think of, which is a little confusing because we haven't talked about cardiac rhythms. So what we're going to do is we're not going to worry so much about the rhythm at this point because you guys are going to spend several weeks on cardiac dysrhythmia interpretation and so on here in a couple of years. So no need to worry about that. But what at least I want us to be able to do is to look at an ECG printout. And you guys did this in anatomy and physiology, I would hope, where you did, you remember Ethan Alvin's triangle and hooking up limb leads at least, and then printing out at least view 1, 2, and 3. That's really as far as we're going to go here. So everybody can see this. This is a PQRS-T complex. You guys remember this from anatomy and physiology? Okay. What this complex is, this is actually the electrical activity, right? This is looking at the depolarization and the repolarization of the heart, right? And it's looking at different areas of the heart. So if we look at the heart, where does it all start? In a normally functioning heart, where does it all start? The SA node, right? So I have the SA node here. I'm just going to circle it. So it all starts here at the SA node, okay? And then that wave of depolarization travels through which area of the heart first? Through the atria first, right? So it's going to travel through the atria here, and it's going to depolarize the atria, and hopefully what will happen to the atria when they depolarize? Hopefully what happens? They'll contract, right? Just because they depolarize, does that mean they're going to contract? No. So when we look at this on the monitor, this does not mean the heart is beating, okay? The ECG does not mean the heart is beating. This only tells us, hey, there's depolarization and repolarization, but there need not be contraction, right? And a good example of this is, let's say that someone were to run into this room and shoot me through the neck and maybe hit my carotid artery on the right side here. And in a minute, I lose all of my blood, right? I bleed out. I fall to the ground, and you put a cardiac monitor on me. What do you suppose you'll see, electrical-wise? You're going to see something like this, right? I'll have electrical activity in my heart, but I've bled all my blood out all over the place. It'd probably be a big mess. Would I actually have a heartbeat? No, because there's nothing to beat, right? So that would be a prime example of you can have electrical activity and no mechanical activity, no contraction. And we see that in patients that have bad traumas. They lose blood, they lose a lot of blood. And we call that PEA, or pulseless electrical activity. You don't have to memorize that now. That's something we'll talk about a little later. Okay, so once the atria depolarize and hopefully contract, what node does the signal go to next? To the AV node here. And what happens at the AV node? What's the job of the AV node here?
For the ventricles.
Sort of. What do do you guys think? So what's the whole purpose of the atria contracting? What do they do? What does atrial contraction do? It fills the ventricles, right? It preloads the ventricles, right? Now, the wave of depolarization moves through pretty quick, right? Through the atria, pretty quick. Do you suppose that depolarization will get through the atria before they have time to fill the ventricles? Yeah, it actually does. So the job of the AV node is to stall, to kind of hold that impulse. They say, hey, hold on, give the atria some time to fill the ventricles up. Then once the ventricles are full, the AV node goes, okay, signal, go into the ventricles now. So the signal, there's a momentary pause here, and that gives the ventricles enough time to fill up, and then the impulse travels through the bundle branches and out into the His-Purkinje fibers of the ventricles, and I have ventricular contraction. Well, the ventricular depolarization, and hopefully I have contraction. And we can look at the ECG down here, and the different parts of the ECG, these different, the P wave and the QRS and the T, these correspond to electrical activity in different areas of the heart. And so what I'll do is I just put some arrows here. Maybe. Okay. So the P wave here, everyone see this little bump here? The P wave is the SA node firing, okay? And you can see a little line there. Is the SA node firing and the impulse traveling through the atria, okay? So the P wave is all atrial. And you guys see this little line here, this little flat line here after the P wave? This is a little pause. What do you suppose that pause is? That is the pause at the AV node, allowing the atria to contract and fill the ventricles. So there's the AV node, there's my pause. And then I have this big complex here. This is called the QRS complex. And that represents what? That represents the ventricles depolarizing and hopefully contracting. And then I have the T wave right here after the QRS. Well, what does the T wave tell me? That the ventricles are repolarizing, right? They're getting ready for the next contraction. Everybody's okay with that? Well, everyone would agree the T wave is the ventricles repolarizing? Do you think the atria has to repolarize? What do you guys think? Does the atria have to repolarize? Yeah. Why don't we see that on the ECG? There we go. Atrial repolarization happens here, but we have the QRS, so it's buried within the QRS. We don't actually see it because the QRS is so big. But the atria do repolarize, but they repolarize during ventricular depolarization. So that's why we don't see it. Okay, is everybody at least familiar with the basic physiology of the heart there? The basic way things depolarize. Everybody's okay? All right. We're going to make it just a little more complicated now. The action potential. I want you guys to tell me what happens with an action potential. So imagine that I have a myocardial cell here. Okay. What happens with an action potential? With depolarization. That's what an action potential is. What's going on here? Okay, so sodium normally lives where? Inside or outside of the cell? Okay, so it's a primary extracellular cation. So I'll draw that in blue here. Sodium, sodium, sodium. What normally lives inside of the cell? Potassium. So I'll draw potassium here. Okay. And when we are at our resting potential, what we call resting potential, so not during an action potential, but just when the cell's hanging out, not doing anything, potassium normally lives inside, sodium normally lives outside, and it's when sodium rushes in and potassium rushes out, I have a change, right? the potential, the electrical potential across the membrane of this cell changes, right? And that is what we mean by depolarization. Because normally my electrical potential across the membrane is about, negative 90 millivolts, 90 to 100, 110 millivolts. That changes and becomes a positive potential, and it is that change in electrical potential that is indicative of an action potential. Okay, so there's a way that we can look at that. And that'll be very important to understanding how these cardiac agents work. And that is this here. So let's dissect this. Do you see down here at the bottom? This is a QRS and a T complex. Everybody's okay there? Okay. So this is what we see on the ECG down here, the QRS, T, okay. We don't actually see this other thing. Okay, so this is what we see on the ECG, but this thing here, this big bump here, this represents what's happening with the electrolytes. Okay, this is telling us where the electrolytes are moving, either in or out of the cell. Is everybody okay there? That we're not actually seeing this on the ECG monitor. We're seeing this. But this is a graph of what's happening to electrolytes, or to ions as they're moving. Okay? So when the heart is at rest, everybody can see this little flat line down here? Right here and here? Everyone see that? That is when the heart is at rest. Okay? That means that there's no depolarization, and that means that potassium's inside of the cell and sodium's outside of the cell, and the cell's just hanging out. Everybody's okay there? This is what's called phase 4 of an action potential. Phase 4. This is known as the resting potential. So I'll draw that on top of here in red. So the cell is just kind of hanging out doing nothing, right? It's just chilling. It's chillaxing, and it's having a good day. It's not here in class with you guys studying real hard yet. Okay. Now, what happens as we begin to depolarize? You guys tell me. What happens as we begin to depolarize? Sodium rushes in. Would you guys agree? Sodium rushes in. Okay, so as depolarization begins, we move from phase 4 down here into phase 0. See this long straight line here? Go ahead and draw in dark blue on top of that.
So are you saying phase 4 and phase 0, the same things are happening?
No.
Okay.
No. I'm saying phase 4 down here, nothing's happening.
Okay.
I have my negative 90 millivolt resting potential. The cell is chillaxing. It's just hanging out. It's doing nothing. It's basically you guys on Sunday night, either watching the Packers dominate or the Walking Dead, whatever happened in Walking Dead, right? That's what you guys are doing. Well, most of you guys probably. Some of you are studying, but most of you are probably relaxing on Sunday, right? Getting ready for the chaos that ensues during the week. So you guys are here, just like the cell. It's just relaxing. It's not doing anything. So phase 4 is the resting potential. Nothing's going on here. Now, as I start depolarization now, sodium rushes into the cell, right? And that is the phase 0 here, is sodium rushing into the cell. And that's that blue, I just kind of drew blue on top of it. So phase 0, sodium rushes in, potassium rushes out. We have depolarization. Would you guys agree? Rapid depolarization. Okay. Now, over here, so eventually I get to a point where pretty much all the sodium that's going to move in is moved in, and pretty much all the potassium that's going to move out is moved out. And I get into what's called my plateau phase up here, and maybe I'll draw that in light blue instead of dark blue. Right. And that is right here. right there. So it kind of plateaus off a little bit. Do you guys agree? Okay. So I've now depolarized the cell. Would you guys agree? So resting here, depolarization, I've depolarized. So what do you suppose is going to occur in here now? Specifically phase 2, right here. Not quite. Do we have to have contraction now, right? I've depolarized the cell, and hopefully that depolarization causes contraction. Well, what electrolyte is involved in contraction? Calcium. So in phase 2, I should see a movement of calcium into the cell, right? And let's see if we're right here. Yes, phase 2. Calcium moves in, and hopefully I have muscle contraction. So you guys can see that this is an instant, is it? I have depolarization, but I don't have contraction occurring at the same time. It takes a little while for that depolarization to cause contraction. Everyone would agree? Okay, so now I move into phase 3, and what do you suppose happens in phase 3? That's repolarization. I'll draw that in green here. So where is sodium going to move? Sodium is going to be pumped out of the cell, and potassium will be pumped back in. And what do you know? There we go. And that is repolarization. And then finally, I return back to phase 4, the resting potential. So is everybody okay there? Does that kind of make sense? Did you guys see this picture in Anatomy and Physiology? And did they explain this to you guys at all? No, I don't know why they never explain this. Yeah, that's all they say. It depolarizes.
Is this on your PowerPoint?
This is. All of this is on the PowerPoint.
Okay,
yes.
good.
Yes. I don't know why they didn't take a few extra minutes to go, hey, it's just the movement of electrolytes. And if you guys understand where electrolytes move and when they move, this makes perfect sense. Now, why did I go over this? Because now when we start talking about medications, certain medications are going to act maybe here during phase 0, or maybe here during phase 3, or maybe here during phase 2. And when we start talking about where the medications work, knowing this makes it much easier to understand the pharmacology of some of these cardiac medications. Okay, you guys good with that? So? Good to go? Okay. All right, so let's go ahead and move on. Okay. There is a major classification system for antidysrhythmics, and this is known as the Vaughan-Williams classification. I bet you guys can't read all this stuff, can you? Don't worry about it. There are only certain things that we're going to talk about here. So Vaughan-Williams classification classifies cardiac medications, and it gives a number to them. Okay? And don't worry, I'm going to draw it on the board so you guys don't have to, worry about having to hunt it down in the book. So it starts at 1, okay? It starts at class 1, and it goes all the way down to 5, down here. Everybody's okay there? Now, class 1 is subdivided into a few subclasses, and we call them A, B, and C. So I have 1A, 1B, and 1C. Okay? Everybody follow me all right? And then I have class 2, and then I have class 3, class 4, and 5. Okay? Everybody's okay there? What do you suppose all these classes correspond to? There we go. These classes, 1, 2, 3, 4, and 5, correspond to that diagram that we went over, and electrolytes moving in or out. And each of these work on a different area of the action potential, or the repolarization, as the case may be. Okay, so let's talk about the first major class, and that is our class 1 agents. What I want you guys to know about class 1, all class 1 agents, 1A, 1B, and 1C, all work on sodium channels, okay? They block sodium channels. These are called our sodium channel, Not very good. These are called our sodium channel blockers. Sodium channel blockers. Okay, so they block sodium channels. They prevent sodium primarily from moving in. Okay? So they inhibit depolarization for the most part. Would you guys agree? That's not totally accurate, but it'll work for now. All right. Now, do you think we have just one type of sodium channel? We don't. We have different types of sodium channels. And the different types of sodium channels are A, B, and C. For example, our class 1A affect what are known as the fast sodium channels. So 1A are fast sodium channels. Okay. And then type B and type C. Type B are kind of like your intermediate, and type C, 1C, are your slow. So we can kind of conceptualize this as fast, intermediate, and slow. Okay? Now, the medications that I really want you guys to know from these classes is really only one that we run into a whole lot. And that is in class 1B here, and it is a medication called lidocaine. Okay? It's a medication called lidocaine. Everybody's okay there? The lidocaine? Here is a trick question for you guys. I have bad teeth. I end up going to the dentist a lot, unfortunately. I floss every day, I brush every day. It doesn't matter what I do, my teeth just fall apart. So I end up getting lots of fillings, lots of amalgams done, unfortunately. And I generally don't like pain, and so they give me something to take the pain away. And most people say, oh, they'll give you Novocaine. Right? What do you guys think? No. We don't give Novocaine to people anymore. Most people get lidocaine. Because, first of all, Novocaine, there are lots of allergies associated with Novocaine. And because it's ester, it's an ester-based. You don't worry, you don't have to memorize. This is just a pearl of knowledge. It's ester-based. So there's an ester link in there. Allergies are higher, and it has some, the side effects profile are a lot higher of Novocaine. However, lidocaine has an amide bond, a lot fewer problems associated with lidocaine, a lot fewer allergies. And it doesn't last very long. Lidocaine has a much shorter half-life. So if you go to the dentist and you tell them, oh, I have an allergy to Novocaine, you can't, well, I'm not giving you Novocaine, you're going to get lidocaine. So anybody who's afraid of that, don't be afraid of that. They almost always will give you, in the United States at least, they almost always give you lidocaine. Okay, so it blocks sodium channels. And why would we use lidocaine? Well, we use it primarily for something called PVCs, VTAC, or VFib. You guys have all had CPR? You haven't yet, have you? So this isn't going to make a whole lot of sense right now. But what we do is sometimes we will use lidocaine to treat ventricular dysrhythmias. It's not really used a whole lot anymore. And it's very difficult for me to talk about this because you guys haven't had all the courses to really understand this. But when you guys take advanced cardiac life support here in a couple of years, and we talk about giving medications for cardiac arrest in some of these dysrhythmias, lidocaine is one of the medications that we sometimes give, but there are other medications that we give more often, more frequently. But it's still there, and it does show up on your board exams because the NBRC is about 5 to 10 years behind some of the newer guidelines. So some of the newer stuff hasn't filtered its way into the boards yet. So lidocaine is still a medication that you will commonly come across on the boards and in the clinical environment. And often we talk about treating something known as PVCs, problematic PVCs. These are premature ventricular contractions, or ventricular tachycardia, or ventricular fibrillation. We give it IV. It's given intravenously. Normally what happens is we'll give what's known as a bolus, and you guys remember from the first lecture what a bolus is, right? Very rapid, quick dose. And then we follow it up with a continuous infusion. Okay? Another medication that you will sometimes hear about is a class 1A medication, and that's called Procainamide. And we use Procainamide to treat the same things that we treat with Lidocaine. Okay? So the PVCs, VTAC, sometimes FIP, we will see that Procainamide can be used for that. Procainamide, however, has some interesting side effects that we'll talk about here in a little bit. Okay, you guys okay so far? Okay, all right, let's move on. 1C, I'm not going to make you memorize anything from 1C, don't worry about that. Okay, let's move on to Class 2 now. Class 2 medications are known as the beta blockers. The beta blockers. Where do you suppose beta blockers work? What do you suppose that beta blockers block? Beta receptors, absolutely. Beta blockers block beta receptors. Where are beta receptors located?
Sympathetic.
Okay, so they're sympathetic, postganglionic. We have primarily we're talking about beta 1 and beta 2. We actually have beta 3s, but beta 1, beta 2. Beta 1 receptors are located in the heart. Beta 2 receptors are located in the lungs primarily, and you also have smooth muscle like in the uterus. Okay. So if I were to block a beta receptor, let's say a beta 1 receptor in the heart, I were to block that, what would I expect happen to the heart rate?
Go down.
What would happen to the blood pressure? Go down. Okay, and that is primarily what we use beta blockers to treat. Fast heart rates and high blood pressure. These are very common medications for treating hypertension and for treating certain types of tachycardia. You also may see beta blockers used in some cases of test anxiety. People that have very severe test anxiety, they get very anxious and fidgety and tachycardic. And sometimes they will take a beta blocker because it blocks some of those beta receptors and they're not shaking and their heart isn't pounding, and it helps them get through their test anxiety. Okay, so is everybody okay on generally what a beta blocker does? Do you think there are some problems with beta blockers, though? Yes, because what happens if I block beta 2 receptors in the lungs and my patient has asthma or COPD? Might we have some difficulties treating that patient? Yes. We're going to talk because there are actually subclasses. There are different classes of beta blockers that work in different ways. We'll talk about them here a little bit. Okay. The beta blockers that you're going to run across frequently, and you can assume anything that I circle is kind of a blue light special, and on your PowerPoints, I've actually circled the ones for you. The ones that I want you guys to be aware of include propranolol, esmolol, metoprolol, and atenolol. What have you noticed about all these beta blockers so far? The names. LOL, right? If it's a lol, it's a beta blocker. If it's an ane, it's generally a sodium blocker, right? Lidocaine, Novocaine. Well, Procainamide is a little different, but it still has cane in there, right? It's just in the middle instead of the end. Okay. Beta blockers, what do we use? What do we treat with them? Tachycardia. Okay, hypertension. Tachycardias. All right. There are other things, but those are the major things that we worry about in respiratory therapy. Okay? We can give them orally. We can give them IV. Some of them are given by infusion, a continuous infusion. You guys are not going to have to memorize the doses or how to administer them by IV or IV infusion. Just know what they're used for. Yes, sir?
Mr. Bear, what were the other two there?
Propranolol, esmolol, metoprolol, and atenolol. And we will talk about them individually too, a little more detail. So there are basically 4 of them that I want you guys to be aware of. Okay.
You have them circled?
I do.
Okay.
I do. In red even.
Yeah.
Okay.
PowerPoints, they're not. Yeah, I'm looking at the PowerPoint right now, they're not circled.
They should be red.
I know they're not.
You should
Maybe
keep
we
clicking
click
through.
again?
Yeah, I clicked through and they're not.
No? Oh, well, circle them.
What do you mean?
Circle them. That must be one of the things that didn't translate. But
Oh, yeah, later on.
later on, they get circled.
4, 5.
Yeah.
Okay.
Okay. Yes?
So if somehow they're given a beta blocker,
Mhm.
and is there a way to reverse that right away?
There is a way to treat beta blocker overdose. If somebody overdoses on beta blockers, we give them a medication called Glucagon. And this gets into a little bit of toxicology, but basically, if I block a beta receptor, what are my cells not producing? Well, what causes bronchodilation? What chemical messenger mediator? What chemical messenger mediator ultimately will cause bronchodilation? We talked about it. Cyclic AMP, right? So if I block a beta receptor, the beta receptor doesn't change conformation, G proteins aren't activated, adenyl cyclase isn't activated, and ultimately cyclic AMP is not created, right? Well, I can give glucagon, and glucagon works through a totally different mechanism to cause the production of cyclic AMP. So I can kind of get around, it's kind of through a back door, if you will. Now you guys, if some of you that work in medicine, you may have heard of glucagon. It's actually a medication we give to help increase blood sugar levels in people that have very low blood sugars. We can increase blood sugar by increasing cyclic AMP as well. But as far as reversing them, there really aren't any ways to other than just let time take its course. Let them be degraded. Yes, sir.
I was doing clinicals at MMC, and a lady came in with SVT or sinus tach.
Supraventricular tachycardia.
Yeah, and she
Yeah.
was up to like 260.
Yeah.
And they gave her something, and it shot her down to like 20 heart rate, and she went back up.
Yeah, they didn't give. We'll talk about what they gave her. They did not give her a beta blocker.
No.
They gave her something else, and I actually have a video of that. It's very impressive to see. It's interesting. Okay, so class 2, beta blockers. Class 3, class 3 are known as primarily potassium blockers. They're actually far more complicated than that, but we can, as a general rule, we can call class 3 agents potassium channel blockers. There's only one agent on that list I want you guys to know, and that is that it's actually used very commonly, and it's called amiodarone. Amiodarone. Okay? We use this to treat the same things that we would give lidocaine or procainamide for. VFib, VTAC, and certain other types of tachycardias. Okay, amiodarone. It's a class 3 agent, potassium channel blocker. It's much more complicated than that, but this is primarily what we can say it does. A major respiratory side effect I want you guys to memorize associated with amiodarone is pulmonary fibrosis. Amiodarone can cause pulmonary fibrosis. And believe it or not, when I took my clinical simulation exam, I had a patient that was just started on amiodarone, and they were having some difficulty breathing. We did pulmonary function tests, and they had a restrictive disorder, and lo and behold, they had pulmonary fibrosis associated with taking amiodarone. So that's one of the reasons that I want you guys to know this, because it is something that can come back to haunt you, if you will, on your clinical sims, which is an interesting exam we'll talk about a little later on. Okay, everyone's okay there? That's the only one from the class 3 list that I really want you guys to be concerned about. Okay, class 4 Class 4 agents are known as calcium channel blockers. Okay? Calcium channel blockers. What do you suppose they block? Calcium channels. All right. There are a couple of those. I want you to be familiar with the names. The two ones that you'll run across are verapamil and diltiazem, or cardizam. Diltiazem or cardizam is the most common one. There are many others, but diltiazem or cardizam is the one that I want you guys to be familiar with, that name. And that is a calcium channel blocker. We use calcium channel blockers to treat many of the same things that we use beta blockers for. We use them to treat hypertension and tachycardia. And all kinds of different types of tachycardias. It can be SVT. It can be something like atrial fibrillation or atrial flutter tachycardias, things that we haven't really talked about at this point. They'll become much more clear in a couple of years. Okay, everybody's okay with Class 4? Class 4, calcium channel blockers, verapamil, diltiazem. Diltiazem is the big one that we'll run into. Okay? And finally, way down at the bottom, we have our Class 5 agents. Oops, go back there. Class 5 agents. And these are agents that work in strange ways. These are what we call our unclassified agents. I want you to be familiar with two medications from Class 5. And these two medications are known as adenosine and digoxin. Okay? Or digitalis is the other name for digoxin. Okay? Digoxin is a positive inotrope medication. It's positive, has positive inotropic activities and negative chronotrope. So what does it do? Positive inotrope, negative chronotrope.
Increases the contraction.
Increases contraction and decreases rate. Okay? Digoxin is often given to patients that have things like congestive heart failure, where the heart is failing. We often see digoxin given to patients with atrial fibrillation because it helps optimize ventricular contraction. Okay? There are lots of side effects associated with digoxin, and we'll talk about some of them a little later on. Adenosine. Adenosine is a medication that we give for tachycardias, something called SVT, supraventricular tachycardia, or where the QRSs are very narrow. What adenosine does is it creates a block, and it blocks the SA node from the AV node. It blocks that pathway off. So what do you suppose happens to the heart when I give adenosine? Yeah, it decreases. I have a heart block. Sometimes I have what's called asystole, where I have several seconds in some cases of no heart activity whatsoever. And the reason that we give adenosine is we want to block the impulses and hope, in essence, stop the heart, if you will. And hopefully, once the adenosine wears off, and it has a very short half-life, it's only a few seconds, once it wears off, hopefully the normal pacemakers will kick back in, and I'll be in a sinus rhythm. Does that make sense? Okay? And I'll actually show you a little video of it, because it's really interesting to see. Patients generally aren't comfortable when you give them adenosine.
So it's like a restart button?
Almost. It's almost like a restart button, but it can be very difficult to watch because your patient will be in asystole. You know, they'll have what the laymen call it a flat line on the monitor, and you're looking at it going, come on, and your patient, is getting dizzy, and they're like, oh, I don't feel so good. Like, yeah, your heart's not beating, and it's very difficult to watch.
Do patients also do like stress testing?
Yeah, they'll usually give dobutamine, like stress testing. Some of them they can give adenosine as well. Yeah, same thing. They're not very comfortable at all. Okay. Okay. So let's talk about effects on the action potential. Your Class 1 agents and your Class 3 agents will affect the action potential. And you guys remember this little graph from earlier, right? So let's look at class 1A agents here. So this black line here, everybody can see this black line? This black line is what my normal action potential looks like. Okay, everyone's good there? Now, the class 1 agents block sodium channels, right? And when I block fast sodium channels, I'm going to draw here in red, hopefully, how that changes the action potential. So can you guys see how it's kind of shifted it a little bit over to the right? It's been shifted over a little bit. Everyone see that? Okay. Class 1B agents. So I'm going to draw that in black here, the normal. And you can see here the class 1B agents have kind of been shifted. It gets shifted a little over to the left, right? Okay. The 1C agents, you can see that the first part is shifted over quite a bit here. But otherwise, it's fairly normal. And then my class 3 agents, excuse me, my potassium blockers, I'll draw the normal action potential in black here. And in red. Okay, everybody's okay there? What do you notice about the class 1A and the class 3 agents?
They end the same?
Hmm?
They end the same?
They what?
End the same?
Okay, yeah. So you can see that this the right-hand part is prolonged. And what's occurring over here? Repolarization. Class 1A and class 3 agents prolong repolarization. They make it longer. There is a very dangerous problem that occurs when we prolong repolarization. And that's not something I'm going to go into a whole lot of detail here because it really won't make a whole lot of sense. But when I prolong repolarization, I can cause them to go into a very dangerous type of ventricular tachycardia. Okay? And that type of ventricular tachycardia is known as torsade de pointe. Torsade de pointe, which is French for twisting about the points. It's very characteristic type of tachycardia. It looks very strange, and it can be very dangerous. It can be very deadly. Patients that take these medications are actually at risk for sudden death if they're what we call their QT interval, because the T wave, right, is where I have repolarization occurring. If that becomes too prolonged, or what's known as the QT interval, something we'll talk about much later on, as that becomes prolonged, the longer it gets, the more likely they are to have this, and the more likely they are to die. So patients that take medications like procainamide or amiodarone, we need to monitor them very closely for these kinds of problems. Okay, so blue light specials. So agents I want you guys to know, well, we've already talked about them, but I have them circled in red anyway. Okay, let's move on. Are you guys okay with those agents that we talked about? Okay? The physiology is okay. Again, I'm not going to make you memorize all the doses and all that, but know the classifications and generally where they work, what their general effects are. Okay? Now we're going to talk about something called pressor agents. Okay? These are agents that we give to increase heart rate, increase blood pressure, and things like that. I want you guys to think of these agents on a continuum. We have beta 1, beta 2, and alpha 1 receptors. Would you guys agree? Okay. So, let's talk about beta 2 receptors. There is a medication called dobutamine. Dobutamine, it is a sympathomimetic medication or an adrenergic, so it mimics the sympathetic nervous system. Dobutamine acts upon beta-2 receptors. So if I were to give somebody an infusion of dobutamine, what would I expect to happen to them? Increase heart rate, yeah. I would expect an increased heart rate. Or would I? Yeah, that should say be a beta-1 receptor. So cross that out on your notes and put beta-1 receptors. I should expect my heart rate to increase. What about the contractility of the heart? Would I expect that to increase? Yes. And we will, sometimes in critical care, in the ICU, you will see patients receive dobutamine that have a heart that is failing. It's not working very well. And they may give them dobutamine to make the heart beat a little more effectively, a little more efficiently. Now, it can make the heart beat faster, and that can cause the heart to use more oxygen, which can ultimately harm the heart. So we need to be very, very careful when we use these kinds of agents. We actually won't be using them as respiratory therapists, but you will have patients on these different agents. So that's dobutamine. Okay. I now have alpha-1 receptors. What do alpha-1 receptors do when they're activated? Vasoconstriction. So what do they do to the blood pressure? Increase the blood pressure. Okay. The major agent that we worry about with alpha-1 is called norepinephrine or Levophed, and another medication called neosynephrine. If you guys remember, I talked about neosynephrine earlier, right? For nosebleeds, for controlling nosebleeds. We can also give it IV as an IV infusion. These two medications, norepinephrine and neosynephrine, act upon alpha-1 receptors to cause vasoconstriction and increase blood pressure. These can be very helpful in certain types of shock, like septic shock, where somebody is having shock because they have a bacterial infection and there's lots of endotoxin being released, and their vessels are very dilated and very leaky, or what we call permeable. These medications can help to constrict those vessels and increase the blood pressure. Okay? And all of the above, epinephrine. We can give epinephrine in the IV. Epinephrine, as we know, works where? Everywhere. It works on all of your adrenergic receptors, your alpha-1, your beta-1, your beta-2, all the above. Okay. There's also another medication called dopamine that is a pressor, but I'm going to talk about that in a little more detail here in just a little bit. And what I'm going to do, guys, is let's take a break. Let's make it kind of quick, though. Let's make it 5 minutes, just so we can get through all this, okay?